group function, because they all been studied on a patient who has no problems, occlusion problems. That's why they've been working on them. Okay, so there's people who has occlusion problems. Those cases sometimes will not work. But some of the cases you probably see on the Facebook, on social media, the people do the cases, but you don't see the follow-up. Because they know it's in a few days, it's what they built, it's already failed. Okay? And what you do. That's why what you see in the cases, people present the cases, was been successful. But most people like you trying to find that's what failure, how you fix them. Okay? So I'm going to show my failures and my success, and what I did, what was wrong. Okay? So about the guidance, once again, the guidance been changed. Okay, and again, only Dawson who creates the unique pathway for these patients, and that's what's most important for you all guys. Okay, because you're going to see some patients which you create the guidance, it didn't work. So the question you have to ask yourself: if the patient had the canine guidance in the past, it didn't work for them. So what do you think? It's why you have to create the treatment they have is unnecessary. Okay. So my job is today is to bring your brain, okay, and do like a CSI, okay, to go through the cases. Why you're doing this? Why you're doing this? I'm not going to show you this. Do this 1 to 3, but I want you to use your brain, okay. So when you cannot use CR, the one you cannot use neuromuscular, okay? I'm not sure it's how far you know the anatomy of TMJ, the problems of TMJ. I'm not going to discuss it. If we have time, I'll probably touch that subject. So when CR, when the joint is in pain, we cannot load, okay, load, they put pressure, okay? You can't use CR.
So you deprogram?
Deprogram, what it does, it's loading the joint, and you can't. Okay, I'll go with it's why I'm telling you, it's when we go through this, I have to go back again. So, so you can't use, you have to use this, neuromuscular, because it doesn't load the CR. It's not in CR position. The problem with neuromuscular, because what you have is the joint is positioned more forward, but if the joint doesn't sit in CR, a patient grinds the teeth on the back. You'll see some patients there's no wear in the front, and there's wear only in the back because it doesn't sit. Okay? There's no occlusion problems. He's fine. If the only problem he has is to be in my office, because in 2 weeks he's gonna have a wedding. Okay, his future wife asked him to come back to us so they can build the front teeth. Okay, when he take a picture on the wedding, they look nice. That's the only reason he came to my office. Nothing else. He doesn't complain, nothing. Okay? So what the John Coy says, the ugliness is not a disease. Okay? So it doesn't mean it doesn't fit again to your philosophy. You have to jump and start treating. What he says also, do not treat the problem patient doesn't have. Okay? So what you need, when you go, is again questionnaires. In the questionnaires you will see the medical history, the dental history, and every questions you have, there is an answer to them, okay, explanation. So that's how you go through the test and asking the patient if they has a problem or not. Okay? So you'll see that the composites, it was not done by me, by my associate. Okay? So look at his occlusion. You can see the position lateral incisor. He built the composite to make sure that it's more even. Again, he didn't break the teeth, nothing. Okay? It's beautiful. Okay? So that's why you see that the occlusion sometimes, you don't have to be strict. It's I'm here, and you have to build this one. Okay? Any questions about this patient? Alright?
How old is that patient?
Probably like 20 something.
So
27, 28.
is there any concern about like what they're going to be 68?
What would you say? What would you say to this patient if it would be patient of yours?
I would recommend they see an orthodontist.
Why?
because without any occlusion at all, is he only on the molars?
Just
Is there any
one
wear on the
more.
molars?
Nothing. Do you see where?
So there's no wear at all?
Yeah. I have 60-year-old patients in our practice with
They
that.
look like that?
With open bites, yeah, and nothing.
So but they have no occlusion at all?
No.
Or should I just go back to the other picture?
Posterior stops and that's it. One stop.
One stop. Because I have patients that come in that look a little, they have more occlusion in the posterior, but they already have significant cupping and wear. But they
That's
just
why you have-
hit like 2 molars in the back posteriorly.
That's why you have to see
And
that.
they're like 17, 18, that age.
Yeah, you have to see that if there is something else probably done with this patient, you also have to figure out that when you see the picture, okay, you don't treat the patient by morphology, okay, because the wear or something else. You have to keep in mind and ask yourself a question: is it something active right now, or it was active in the past, and he stopped doing it? Okay, so if you know that at the age of 17 or 15, so in every occlusion, what you're going to do is you need reference points. And the reference point, I'm going to go through the face, white and pink. Okay, so that's how you're going to go with this. But look at these images. Okay, why I brought this patient? It's not my patient, but I brought this patient for you, so probably to see it. So you see the position, and before I make a judgment, I want to know why she has the position of those teeth, that level. So look at the bite. You see it?
What is I don't know.
Okay.
They filled it
So
up.
let me put this way. If I put this on Facebook,
Style it.
I'll be turning apart
Style
the
it
first
again.
of the dentistry I did for this patient. Okay, but let me put it this way. This patient, she has a problem with the joint. She can't load the joint. She has a lot of pain, but she also has financial problem. She can't pay for the dentistry. Not at all. So she has a lot of pain, and the dentist, to help her, what he did, he built the occlusion with acrylic, okay, to support the joint to relieve the pain. So for her, he's a hero. On a Facebook, you know what's gonna happen.
Right.
Okay, so what's gonna happen is when he built the occlusion, it's intrude upper posterior teeth, and when intrusion happens, the joint starts hurting again. So she come back again, you put another layer, and put another layer, and put another layer. That's what you see in the picture. Okay, now she came to him because now she has money, and she can do the aesthetics in the occlusion. So we can't judge the patient by the look. So we have to know the history, why. Okay? You see this position? So that's a spear case. Okay? Why I brought this case, I'm going to show you how we proceed, how we accept the patients. So this patient came to him is because of the second premolar. She has sensitivity. He also find out that she has a problem on the second molar, and the first and second molar on another side. So we have 3 type of offices or practices. Number 1, I'm going to take care of only in emergency, and whatever's going to happen next time, I'm going to come back for full checkup. I'll tell you the rest of the treatment. So I don't want to scare her off, because if I'm going to present all the treatment plan, she's going to leave and I'm not able to do even the emergency. Okay? Sounds familiar, everyone? Okay? Second office, insurance-based office. Second, so what? Prognosis. The last one. Treatment. So what it means? How do I see my patients? When patient calls, my front desk is what I did to you. I want you to go to my website and fill out the forms. Okay? What does forms do for you? Okay? So whoever did fill out the forms, the only probably the person, she was thorough, he was thorough, it was just fill out, okay?
Masters, he said be thorough.
Okay, so what the difference? Why you need this? Years in a normal bite to wear just 1 millimeter of tooth structure. Since the last time we see each other, okay, you lost maybe 2 millimeters, 3 millimeters of your tooth structure, and it concerns me. Okay, see, I didn't say any treatment. People would make mistake because when patient sits in a chair, is oh, you need a filling MOD, I need a crown, root canal, blah, blah, blah. Speak to my front desk, they'll take care of all the emergencies, okay, and stuff. So I usually don't, because people came to you with something different. You tell them $10,000 bill, okay, and they leave. So I want them to take responsibility of what happens to them. Usually you wait, okay, as Mrs. Mays, there's a fracture line. I don't know what propagates, it's all the way down. So this tooth for the rest of your life, it's going to be no higher risk of possible dying the nerve, or possibly you might probably lose the tooth. I didn't say extraction, root canal. Okay, it's something different. Usually I wait. What would like to do? So usually people don't like to be in silent mode, and someone has to speak within 20 seconds. Thank you. Okay, the patient has to speak. Usually if they say, listen, I take responsibility, okay, just do the treatment on an emergency basis, and I take responsibility. What's going to happen is going to happen. Some people say usually what I have to do. Okay, what can be done? Then you present what? The treatment. I did write down what? The prognosis, what my problem might happen. And the last one is now what? Treatment. Just remember, what, so what, and now what. Okay? That's how you teach your front desk, your hygienist, your assistant. Everybody has to be on the same board. Why? You're not presenting the treatment. Patients take responsibility. Yes, it's easy for you to do treatment. Because if the patient didn't take any responsibilities, I'm telling you right now, all the failures is going to happen, they're going to blame you. You know when we recover. There's going to be a lawsuit, something else. To try to avoid this kind of problem. So in this case, whether the insurance based or not insurance based, we present the treatment plan. You can see here, it's usually the treatment plan looks like in regular dental office. So what I'm doing is the Spirit did. He divide the arch in 3 groups. So number 1, what's immediate concern, it has to be treated right away. Second one is need to be treatment, but can be delayed. And the third one doesn't need a treatment, but you want to treat treatment if for cosmetic reasons. So what it means to you? Number 1, 2, and 3. It means you, if there is insurance base, you already schedule number 1 for first year, number 2 second year, and number 3 for third year. So you already put your money on savings account. Okay, that's how you proceed with the case. And I think it's what for the patient is. The patient already knows what the path she has to take, what she needs, what has to be done. Because to inform the patient today that there's nothing here, you have nothing today, you then present the treatment plan the next time, people usually get offended. Okay, they don't trust the doctor. So tell them what you see and let them take responsibility. Because you didn't create this. They came with this kind of problem. Okay? Try not to put a safeguard jacket and save everyone. Okay, let them take responsibility and do the treatment. Is that understood? Yep. Okay. So the same happens to this patient. You can see first year, second year, and you know. You want to take a break before we proceed? So the treatment will go from the back, will go to the front. That's what the problem with some occlusion philosophy, because they've been always treat and diagnose the patient from the back to the front. And sometimes when the case is done, cosmetically, it's not great. Okay, so as I told you, I've been in Russia last year. I teach, and they usually are big in pathology. Okay, school, and one of the famous guy who put his case on dental town, he did it himself, and when he did the case, all his teeth been, inclined in the wrong position, because they never had the problems to fit the aesthetics and occlusion at the same time. They know the occlusion, but aesthetically they can't fit. And he was cursing Coachman, it's Coachman DSD, there's a look at it, and he put the braces back again in order to correct the position of his teeth. It means he's teaching, again, it's mythology. I'm not blaming him, but what I'm trying to say, I try to put all the schools together so it will fit to your practice. Okay? So, number one, I have I'll be choosing paper right here so I can speak to it. So, number one, P1. P1 is your position of your jaw related to the skull. Let's say it's CR. Okay, it's position. It's only 3 ways of doing it. Number one is a CR. And you see here, that's another one, it says adapted center posture. Does anyone know what ACP stands for? No? Okay, let's look at it. Another one, MIP. And the third one is a neuromuscular myocentric. Okay. So when you're going to take MIP, why it's the first one? MIP you're taking it when you accept the patient's MIP, maximum declaspation, means the occlusion is working, there's no problems. You're taking the reference point. So you do this MIP when you do filling. You're doing crown, single crown. You're not changing the bite position. Okay? So when you see the patient, the bite is good, I'm taking this bite as my reference point, it's MIP. Done. Okay? So you do veneers, you're not changing the bite. You put veneers. Done. It's working for you. The myocentric I already told you. What you need is tense machine in put position. So what the CR means for you? This articulator. This articulator I'm working with. It's Panatin. Okay? The whole articulator is the same. Okay? Don't buy anything expensive. Okay? Because if you have no idea how to use it, you don't need it. Okay? Most of the time you need semi-adjustable articulator, number one. Okay? There's another, there is no study in the world, okay, who compare all the articulator and say this one is better than another one. There's no study. So don't buy on anything that people say that this is the best. As you notice, when we open the mouth, okay, we have rotational and translation of the joint. Okay, it's rotation, it's at the beginning, then translation. But most people say that even when you rotate, it's already translated. What you have here, articulator, is only rotational axis. Okay, there's no translation. Okay, so this, as I say, doesn't represent what you have here. That's why I'm telling you, don't buy anything expensive because nothing here to represent what the patient has. Second, why doesn't the models doesn't represent patient have? Because we have what? Ligaments. They move. Doesn't move. Okay? So what you see sometimes here, it doesn't reflect sometimes what's in the patient mouth. But I try to eliminate those biggest mistakes. So what the CR for you means, patients. If you wanna again buy it, so you can go to Great Lakes Orthodontics. Just tell them that you've been at my seminar, you will get a discount. I have no contribution wherever you buy, you sell, I have no care. Okay? So this is for the patient. Usually this is for normal. And I show you the patient. See the yellow, it's your cartilage. Okay? The bone, the lines has to be aligned with each other. Okay? And it's your normal bite. If there is some kind of interference, that's why I have clicking, the joint problems, something else. Okay, if we get to the point that I have to go with the joints, what appliance we have to use, anatomy, why the differential diagnostics, I'll show you more. Please. I don't want to ask these questions. Okay, so what is CR? CR, what you need is for the muscle right here in the brain, we have a memory chip. Okay, we call it engrams. You know the engrams? Heard it? Okay, so when patients open and close, that's why we're not banging against each other's teeth. Okay, so we create the engrams, the memory right here. So when it's CR, it has to be open and close to create the memory. So when the patient closes, okay, he doesn't have any eccentric contacts. Number one. Second is with the centric relation, you can open and close the arch. That means you can open OVD, occlusal vertical dimension, okay, or you can close. So with the CR, you can do that. With the neuromuscular, okay, you can't. Because what happens is, when a patient opens, okay, and define the position of the muscles when they relax, that's a position of your bite and also position of your joint. And when you send to laboratory might say, listen, the position of the lower jaw you gave me, the OVD, that is going to be too long, and the patient's not going to be human. Okay, or the OVD is too short, I can't fit those teeth. And they can't do anything because the TENS machine is telling that this, the muscles are less activity. That's when you have to build the occlusion. That's why you're stuck with the neuromuscular. You can buy those machines, no problems. Okay, it's going to cost you $1,000. You can use them, okay? But I don't want you to see that what the central incisors have to go to the face. Okay, determine. It's nothing to do with occlusion. I want you to understand it. Put the teeth in the position where it's supposed to be. Don't think about occlusion. Any kind of philosophy or something else. Okay? Second, it's going to be upper posterior teeth. So what it did for you? This is the position of your maxillary arch. And don't forget, this maxillary arch is for aesthetics. That's what you do. Again, there's nothing to do with occlusion. Let's position the teeth, upper, front, and upper posterior. The third one, lower anteriors. Position those teeth so you know where to position them. And number 4, as you know, it's going to be lower posteriors. So, for example, I'm going to show you the patient who has difference in occlusal pain. Let's say what it means to you. They might be no. Okay? So if you increase, it means what you have to take as your reference point. What it means to you also, when you have no teeth, you have only 2 reference points you can reference them. It's going to be your CR or it's going to be muscles. Okay? So we already took away the muscles, we're left with the CR. So if I increase any of them, I need to take a CR position. Okay? So look at the patient and see what you do. Okay? It's like you do set up the occlusion. What you do upper central incisors first. Okay? You look at the face. If it fits to the face, then you put lateral incisors, then you do canines, okay? Then you do posterior teeth. So when you're done with the cosmetic part, you don't touch. Okay? If you need adjustment. Cosmetic. This is functional.
Lower.
Lower function. Okay? How it works here. So you put upper ones. Okay? You set up the teeth that you came with the static part. Okay? If we have to increase OVD, what you do? Increase the pin. Okay. What happens to position aesthetically? You already distort. Understand? So everything what you do is how I'm gonna relate face to articulate it without distorting it. As my lab technician will notice what the position of the jaw and the position of the bottom. So when you raise the pin, it's for your lower jaw to function. Okay? This for my cosmetic. So what I do here, look, this is my jig, who's holding my upper articulator. Okay? If I need to increase my central incisors, I say 3 millimeters. I don't do this. You see the dial here? I can dial 3 millimeters down and I keep the same aesthetic position on the face and articulator. I didn't change the position from the joint to my centrals. You right? Understood? So when I did this, where to position it? So for example, if the patient is, when I do repose, and I see the position of my teeth are normal. When I smile, I have only 3 millimeters of tooth structure, worn down. So it means to you that the reference point for the incisal edge is there, but the length of the tooth is not there, the gingival level. It means the tooth moved. Okay? It moved, now you have to go bring the back position. Either you want to have surgery, number one, or you have to do orthodontics. We'll figure out which way we have to go. Okay? I just want you to just go to the minds, we'll get the cases so you have better understanding. And the pink position again, also the gum and your papilla. Okay? So you have to look at the papilla and position it. Papilla has to take 40% of your tooth length. Okay? Some people say 50%, I get to 40%. Okay? If you see the position of those papillas, you'll figure out either do orthodontically to make them even with the rest of the teeth or not. So the gum level you have to also keep in mind. The gum level has to go 6, 8, 9, 11, has to be in the same line. So you have to see where the position of those gum lines, okay, in incisal edges. Then you figure out the position of the teeth. What you do with the anterior teeth first, then you figure out this, then you figure out this, you figure out this. If you do those steps every time and every day, okay, you will figure out what has to be done without even locks up. Another, for your clinical point to understand, most people, they look at central incisors, but actually you have to look at the canines, not the central incisors. Okay? Because the study which did is those canines are giving you reference points. Because some people have short lip, the teeth not in the right position. The canine is frontiers, central incisors.
Mm-hmm.
Do you like at his age that position?
Yes.
25.
Yeah.
You like
Yes.
it? Okay. So now remember the canines. Okay, relax. Right now. Open, open, open. So the canine, the edge of the canine, has to be level with the lip. You see this?
Yes, I need it.
Okay? So what it means to you?
Yes, come back here.
See the canines.
You got the worst student.
So the canines, okay?
Yeah.
You see the lower lip,
Oh,
okay,
yeah.
upper lip, it's the
Yeah,
bottom
it's
portion.
right at the edge.
Has to be with the edge with the canine.
Okay.
So what it means to you? If the canine is 3 millimeters down, what do we call it?
Superrupted.
maxilla. Okay,
Call it
and
maxilla?
maxilla, yes, upper, yes. And the upper jaw is more down than it should be. It should be, variation has to be +1 or -1. If it's more, he need orthodontic surgery. So I don't need to tell that, listen, I need to relax up, I want to see, I can see it right away. So why I have to waste time? Patients, I said, if she wants to do correct the position of the gums, I said, listen, I can do the position, but it's not going to help you. Because you need orthodontic surgery to get your demand. If it's higher than it is, you need also orthodontic surgery to bring it back.
So what is the measurement? How
The
much
measurement
higher
has to
is
be
the
at
leeway?
0 point, that's what he has right now,
Right,
or plus or -1.
is
That's
normal.
normal.
Is normal, okay, and then when
Okay.
are you recommending surgery?
Huh?
When are you recommending
One
surgery?
point 2.5, no, I'm just kidding.
No. when you have vertical and maxillary excess,
Vertical.
it means
Right,
it's
right,
When you can,
gummy
Yeah, yeah, yeah.
smile, gummy smile,
Right,
okay? And you see that even you do crown
Right.
lancing
it's
procedure,
not gonna work,
Yeah.
it's a little bit like a horse teeth,
right,
but you're not
So
going to achieve the
right,
result.
right.
Because what? It's an anatomical problem,
right,
not the teeth problem.
Sure.
The production.
Okay? So you can see it right away, so you don't have to imagine something else. Look at the teeth and those two pictures. That's why when you guys send me pictures, I said there is no reference point, I have no idea. Okay? And when people send the pictures, I tell you right away, there's no occlusal background on this patient, and I have no idea what problem to look for. So I'm not blaming you, it's everyone had the same problem. Okay? So now you know this, have to see the incisal edge, you have to look at the gum position. So if you look at his teeth right now, give him a big smile. Look at his gums. Do you like the position of his posterior teeth?
Oh yeah!
Okay?
Could be a little one.
So his teeth are a little bit shorter, okay, and it's showing a little bit more gummy smile. Okay? So the question,
What do you want? We have small teeth.
yeah, question would be, so people, before you jump to the treatment plan,
right.
okay, I have to see, remember those 4
Or
departments, the
fill it
perio,
out, yeah,
okay, bioaesthetics, occlusion, and other stuff. So if this patient, for example, very sensitive, carries all over the place, and people say, do crown lancing procedure, okay? And what's going to happen to you, for example, if you do crown lancing procedure, you expose what? Cementum. So he's going to be more sensitive, okay? He's going to get more caries because there's less, covered that's the structure, okay? So you're making more damage than good, okay? So this way, this is maybe the ortho is going to be good to push those teeth up and build the occlusion. So it will not cause sensitivity in other, okay? There's nothing, everything is pure, normal, okay? That's what we call CR position. Another one, it's Dawson came up with this, it's called ACP. Remember I told you ACP? Adapted Centric Posture, okay? What it means to you, that's when the patient, you have a patient who has clicking, okay, there's joint problems,
Yeah.
but has no symptoms. You do any tests on the patient, and the joint doesn't respond negative, means there's nothing there, okay? It's healthy, means it's already been healed. What it means to you, it's never gonna be a real CR position, okay? It means you're going to put in dental history, it's going to be ACP, Adapted Centric Posture, okay? And that's what you're going to use as a reference.
So, and that's the only patients who are clicking, you're saying, without it?
Clicking, any kind of joint problems they had in the past,
You guys can check
there's
that later.
there's a crack because something else.
Right.
As well.
So
Yeah.
basically, you're gonna use their MIP.
ACP. ACP.
Well,
If-
how are you gonna determine
if you-
what
if
that
you-
is? Is that where their maximum intercuspation is? Is their ACP?
It's still leaf gauge and central plates.
When you look at the patient, what you're going to do? You're going to use his MIP as your reference point.
Okay,
That has to do with ACP,
okay,
okay, with CR. Okay?
okay.
Or you're using CR or ACP, but you're not going to use your MIP.
Okay, so you're just naming ACP when you're it's that
Yes.
patient, that same
Example,
patient.
If I do a full rehabilitation case,
Right,
okay, I'm going to grind all the teeth,
okay,
okay? And I know this patient already had a joint problem in the past.
right,
What it means to us, she doesn't have any kind of problems right now. No pain, nothing. I also do the test, nothing. Okay? I always tell Miss Johns, okay, you have this ACP. It means your risk is high forward. Okay? And I feel the position of comfort when I don't have pain. It's like the patient with acrylic. I can build my occlusion that way, okay, put underlays, and I'm done. That's position of comfort, so I can work with it. That's why the orthotic working that way. So they put you in a position so you can function and there's no pain until this area is going to be resolved. Okay, so now we have 4 classifications, yeah, of the CR. So number 3 and number 4, you're not taking a handpiece and treat the patient. That's the rule. No handpiece. Don't destroy. To answer question to Matt, osteochondritis. Okay, osteochondritis usually happens to women the most. Okay, it's a cartilage problem, and usually you give them glucosamine as like a 1,000 units twice a day to replenish those cartilage type of 1 collagen, and usually you will hear not a click but crepitance because it's rough. What do you want to ask?
The 4, you said that the 4
Yeah, number 1 is
classifications-
CR,
No, those I got, but you said there are 4 classes of
CR position.
CR position. Thank you.
It's Piper classification.
And the irreversible, is that also like when someone has pain on loading?
Yep.
Is that also considered irreversible?
No, it's, when it's loading, you have to figure out, is it a joint problem
Or muscle?
or the muscle? Or is it something like inflammatory process right here? Okay? If you want to make a clinical, okay, fast. So look at the joint right here. Find the joint, put your fingers here. Okay? And when you find it, when you press against the head of the joint, it's your capsule. When you press against the joint, if you feel pain, it's capsulitis. Okay? So, what you do next? You open your jaw and put your finger and you go behind your joint. Okay? Now you feel what? Retrodiscal tissue. You feel it? The nudge? Okay? And now you probably have to figure out, is it capsulitis or is it retrodiscal tissue? Because sometimes people respond both of them. How are you going to figure it? Another way to figure out you just a retrodiscal tissue is you put your finger here, okay, and press against the head, okay?
Yeah.
When you press, sometimes people say, I don't feel comfortable. You can do everything you want on my patient. They add in some questions because people in different countries, they have different ways of doing it. Okay, so we're adding more questions. Now you can see here the diagram. Everybody who doing research, statistics, as you know, it's if this diagram right here, okay, the bell curve, okay, is too wide, it means it's accepting more data. If it's more sharp, it means it's less data involved and it's less trusted. Okay, so we have 5 diseases in an occlusion classifications. Okay, I'm doing just junk quiz. You're not going to find this in Spear. Okay, so you can have your mini-me. Acceptable. Another one is constricted chewing pattern. Another one is dysfunction. The third one, parafunction.
These are the
and
five.
neurological disorder. Huh?
These are the 5 problems.
5, yes. You already have them here. Okay? You can see that's what they did with population of United States. They divide them in 3 groups. And you can see them, they're in different colors. It means to you that's acceptable, it's only 10%. It's green. It means it's no risk or less risk. Constricted and dysfunction, you're going to see the most in your patients. Okay? And it's yellow. It means moderate risk. And you have higher risk of patients, 10%, with the power function neurological disorders. So when you go through, remember, what, so what, and now what, you will figure out who is your patient and what is your treatment. Okay? So these questions, I'm going to go through this when I'm done with the classifications, because it will mean nothing to you because you have no idea what it is. Okay? So as I said, 80% of your people, of your population in your chair, you're going to treat those constricted chewing pattern and dysfunction. So let's go from the start. Acceptable function. Open up the bullets and I want you to read them. Okay? So you will understand what they mean. I mean, it's efficient of use muscles. I mean, it's normal. Yeah? Okay? You see it?
There you go.
Okay. So this is mini me. It's a mini course, what I just told you. Because if I will give you this, you'll go home, you have no understanding what it means. Now you will remember it when you look at those bulletins. Okay? So, envelope function is normal. There is no problems, nothing. The patient comes and says, no, to all the questions. But it doesn't mean that he is acceptable until you'll get in and you'll see what, so what. Okay, make a diagnosis. Is always if. In any disease, is always if. It means deviation. So it means to you how a pathological condition might exist. What are the pathological conditions? So number 1, you can see extrinsic, localized. It means your diet. Your diet means, you know, it's, those Koreans, okay, they eat those vegetables. Especially, say, you ask a woman, your husband next to her. Not a good question, yeah? Now you know this. You say CSI, now you have to figure out what people do and why. Okay? So now you know this, you can see those cuppings, but the rest of the teeth, you see, there is no wear on them, on the cusps. Okay? So it's erosion. So look at the patterns, what people have. So if I'm going to go for the upper ones, you can see also destroying first molars. The front teeth, you see, not as much.
What about the tori? Is that?
There's no proof. He
Is it
said
the
it's
theory?
stress,
Yeah,
but there's no
theory.
proof. Yeah, there's no proof. No one guaranteed it's because of the occlusion problems. No one's. Okay? So, this is GERD.
So why first molar is more than second molar?
Because they first came out and said
okay.
what age. Okay? So, what I'm saying to you is when I see the patient, but you have some doubts. That's what you're going to do, what's going to happen. You put him on a leaf gauge, okay, or loose jig, right in your office. Let him sit. How do you respond? If you see it's repeatable contact, the same patient bites, there's no problems, you go ahead with the treatment. So I always take a CR position when I do the full rehabilitation cases if I take an MIP, because especially in the posterior teeth. So I want to make sure that where the jaw will move, just in case it's going to happen. So with acceptable function, if you take, and that's a clinical tip for you, before we break, okay? So you take MIP as your reference point, and you're doing crown on number 20, okay? You put a crown, you prep the teeth, beautiful crown came from the lab, beautiful, you love it, anatomy. You cement it, and the patient says, listen, my bite's completely off. I know what to do. Okay? Check the occlusion, check the bite, everything is great, there is nothing wrong. Okay? I said, my bite's completely off. What'd you do to me? Okay? And you say, yeah. Yeah. So you're taking what? Handpiece again,
Right.
because you have no idea what to do. Okay? But to make police here, you
Right.
start what? Grinding the
Grinding it,
occlusion.
yeah.
So make sure she will believe that you did something that's to help you.
Right.
Okay? She calls you again in a week after. Come back. Listen, my back's completely off. What'd you do to me? Okay? It was fine before you touch it. Why is it problem? Okay? You file push down again. Okay? There's a big space already between top and bottom. Okay? There is no occlusion going in like that number 20. So before you start doing it, you said, Mr. Johns, this crown we're going to change right now. It's your primary initial contact. There's possibility when I remove this crown, your bite might be changed. And then we need additional procedure to equilibrate your bite. But we definitely need to change this crown because there's secondary decay underneath. I want you to be aware. If this is going to happen, we might probably do equilibration, equilibrate your bite, or you might probably need braces. Okay? So, would you like me to go ahead and remove this crown? Okay? So I want you to be aware before you start doing the case. The patient has to accept this.
So this is for premolar, right? Because obviously this is a patient
Yes.
who has some sort of group
Yeah.
functional issue, okay.
Can you explain the test with the shim stock one more time? I wasn't
Okay,
clear on
with the
it.
canine,
You put the shim
on the
stock
side.
between the canines.
yes, is going to hold the shim stock. Okay?
Okay.
Means you're fine to remove this
Meaning
crown.
that when you say hold, you mean that there's,
Canine
disarticulates
Tug
the
on it.
posteriors?
Yes,
Okay,
it's holding the bite.
okay,
Just an MIP, right?
Yes.
okay. And
Okay.
then if you
If
put
it doesn't,
if you put the canine there and the bicuspids are still in occlusion with the shim stock in place,
yes.
then the assumption is
canine-
that's the first point of contact.
If, for example, the canine doesn't hold the shin stock, but the premolars they do,
There's space.
like on canines, yes.
Okay.
Any kind of reason. Okay, now you have to find out why. Okay? Understood? Clinical part. So,
You could just use biocopy and call it a day.
you need to buy a copy because there's microns, the difference. Okay, on top and outside on the bottom. And every time it wear the teeth down, what those teeth do? They move towards to each other and closing the space. That's what we call a passive eruption. Okay? You're closing more space. So what you do sometimes when you see the patient, I want to restore your teeth because you have pathological wear on your teeth. Let me do the crowns. If the patient is 60-year-old and lost 1.5 millimeter or 2 millimeters of tooth structure here, and I say, let me do crowns for you. What you do? You remove another 1.5 millimeter to fill the space. So wherever he did within 50 years, you did it within 30 seconds. Did you do damage or destroy the teeth? If we're going to go again biomechanics, we know that there's a study done on adhesive and cohesive. If it's 2 millimeter reduction of the tooth structure from a normal length, your restoration is going to hold. If it's 4 millimeters reduction, okay, it's going to be a catastrophic failures of your restorations. So sometimes those teeth when you start restoring them, okay, even you have adhesive, all kind of stuff. I don't care, rubber dam, not rubber dam, okay, it's not going to stay. Okay, because there is no enough tooth structure to support it. Okay, so what's happened in clinical part? If we have everything is strong, the periodontium is strong, the joint is strong, the teeth are weak, you're going to wear them first. You will see sometimes the upper teeth are more than the bottom one. Okay? The wear on the teeth. Sometimes you see the anterior teeth on top, you put porcelain crowns, but the bottom teeth are wearing down. What it means to you is that most people making mistakes, especially when they prep anterior teeth. What you do here, you see this part? Lingual, right here. when you remove reduction, okay, you don't take enough of the tooth structure from those teeth, from the palatal. And the technician doesn't have enough space. What he did, he built more the palatal. What he did to you, he constricted the space. That's why patients start complaining about it. That's why no matter how much experience you have in dentistry, the occlusal reduction has to be measured, how much you have to remove and create the space. Okay? So that's very important. The other thing what you have to keep in mind, that when the teeth strong enough, but periodontium is not strong enough, you will start creating what? Spaces. And you will see, remember the last one was creating the spaces. And especially it happens to people who has like a number 10 is out, number 8, 9 is out. But you say, when you put the braces to correct the position of your teeth, what you do, you constrict it. And especially the kids, okay, and they came up with the joint problems. Because the jaw doesn't want to move forward, the only way is to go back. That's why you hear start clicking after the braces. Okay? What else you're going to see here? Okay? So with the constricted chewing pattern, people sometimes, what you're going to see, you see the upper and the lower. You will see the wear and that part. But sometimes people wear here and people wear here. Those are the dangerous part. Okay? Another question for you. Which part of the classification, angle classification, you're going to see the most of this wear?
3, 2.
Number 2? Which one's A, B?
2.
2. Division
That's
2.
Division 2.
It's a division 2.
Because it's retro.
So usually it's not.
No.
It looks like it because the teeth, upper teeth here and lower teeth here, that's restricted. Usually it's not. Would you have this constricted chewing pattern in class 3 or not?
There's 3.
On the
Yes or no?
opposing.
Yes. Why is it? Right.
Edge to edge.
When a patient bites, the mesial incline on top, mesial incline on the bottom, and distal inclines on the back, on top. When they bite, they shift the jaw back. So in class 3, you also might probably have a constricted chewing pattern.
Mhm.
It's very important, especially if you do braces. I'll show you the cases. Okay?
So in class 2 you would not?
Again, morphology, classification, angle 1, 2, 3 means nothing. It doesn't tell you how to treat the patient. What the patient, it's just a classification, position of the teeth. But it means nothing
about power
for the
function.
treatment. Okay? So look at this patient. What kind of wear you see here?
Facial or anteriors.
I'll help you.
So they're up there, number 9.
So, sounds familiar when you have veer? Because the patient moves left and right in a crossover position. So look at me. I bite. See my lower teeth, incisors, got in the middle of the upper ones and I'm destroying them. And we'll have to prove that I'm right. Look at the canine. The same as I told you, there is a wear from the inside. So the upper teeth, what was just said, palatal from the top and the facial on the bottom. But when the jaw moves forward and up, when you start seeing the wear on the outside on the facial, and you see the lower incisors, you'll see chipping from the lingual. Start seeing those patients, and you'll see what they do. They will all deny this, I don't do this. Of course they do. Okay? You can see the canine right here. Do you see the? Do you see the chipping on the inside? Okay? So that's why.
Greg, are you gonna define a crossover? Because I heard it called, is it coming up later? Define
Crossover, yes. Okay. Canine crossover, you see?
Right, but what is it exactly? I mean,
It's
is it just literally moving?
it's literally
It
when you
means-
go into an excursion
it
and
means
your,
you
and your
go out,
lower
yes.
is outside the maxilla.
You see the position again? Attrition with the incline when the bite is restricted. Okay, this one, when it's go, left position. Too far. Okay? So when you build your occlusal scheme, it has to be different for different pattern. I didn't say the canine guidance. I didn't say group function. I said the scheme has to be different. Okay? How are you going to determine this? That's why the Dawson, the pathway, has to be different. Because it doesn't belong to any occlusal theory, because everybody discussing here, but not over here. That's a problem. So look at the pathologist, neuromuscular. What are you doing in this case? You have no idea. No one. So what's next? Look from the back. Okay? That's I took from the Facebook. From a patient. And what they discuss, how they're going to do wax up. I already told you. You don't wax up, you kill this patient.
Did you say if you do wax up, you kill them?
So, I want you to look at the lines. There's always, again, the nature is helping you to build your occlusion. What do you see here? You see the wear pattern, but you also can see the line here. So what this line means?
It's making room.
Huh?
It's making room.
What else?
It's the wear pattern.
That's where they
Okay,
stay.
that's- What else? Okay, hold on.
It's flat space.
So guidance attrition.
Yeah, that's where they stay.
So now the most important. From here to here, it's a P3. This line is your P2. You understand? So why is it so important?
You gotta,
I'll go back.
Can you explain what you mean by P3? I mean, is it the pathway or the guidance? Which one? Oh, both?
P3 is the guidance. See the bottom?
It says pathway versus guidance.
Yes. Okay, so this is the guidance. The where. If you look at your P1 paper, it's all in the back here. On a P1, let's say you will add that's the flat surface on the anterior teeth as your reference point. I'll show you in the clinical what it means, what that line means to you. So this line is going to help you how you're going to build your anterior teeth with this kind of patients. So what it means to you? If the patient has a P3 and P2 will squeeze and put the teeth together, and it's your MIP. Okay? It's your home. So the patient squeeze to put the rest of the teeth together. Maybe you told me about the joint. Squeeze, because there's not enough space, and when squeeze, it came out from the joint and creates the lack of soreness in the back. Okay? Because the people have the joint problems with the occlusal problems. So in this type of case, what you have here, when you create the P2, you want to make sure that you will not touch that part if you want to keep that part P2. Because if you start smoothing this part,
change it again.
Okay, your jaw is going to move more back because it doesn't stop. There's no stop. What it means to you, when you build your anterior teeth, and your technician will create beautiful anatomy and it's smooth. Okay, single.
Right.
When it bites, it's smooth. It will slide. What it does? Put the patient back. Sometimes you will see the patient start complaining about the joint or the noise. How the constricted chewing pattern affects the denture, the full denture. The patient might say, "Doc, you made a beautiful denture. Excellent. I can't even remove it. It stays beautiful. But the second I bite, it drops." Because what happens? What usually the palatal seal breaks, when the patient bites in the front, it breaks the seal because not enough space. Okay? That's number one. So you understand?
So
But-
you're basically saying that you're designing the anatomy in that portion of the incisal third.
Okay? So how I told you, remember the what? So what and now what?
Mm-hmm.
Okay, so I explain the patient, this is what the patient has. And I said there is a occlusion problem, I need to take more data. And I say, listen, I want to fix this problem, can you help me with that? Okay, I said I need more data, and I usually charge for that. Okay, patient will come back, and they know, I usually schedule for a couple hours, we're taking more x-rays, pictures, we're taking Facebook, we're taking models. So the patient has to know this, I need more data, I need more information so I can help them. That's why you see this person that's who has a deprogrammer. Okay, I said, listen, this is a price if you want to go ahead and do this. If you want to get me help to get the diagnosis so I can make the right treatment plan for you. If he doesn't want to because he accepts the risk he has, okay, I'm not doing this case because I don't want to waste my time and the patient's time because you forced me to do this. Your philosophy, in my point, in my office, is wrong, okay? So I can't help the patient, he doesn't want to have help because what he thinks is what his idea, that's what we call sway, okay? It's like, see if they recommend me, okay, and they say, you're a wonderful doctor, okay, you can help me with this and probably do those two crowns right now, and let's say all the positive stuff about you. Of course you're proud, I'm the saver, okay, let me do those crowns to help them. It's what we call sway. When people telling you and you in a different level, not in a clinical level, doing something which is not going to be reversible. Okay? What it means to you, for every patient you're sitting in your chair, I want you to treat them as your mother, as your wife, as your son. And it has to be, if you look at your pages, there's always says all this. Okay? All this means you do this all the time without any deviation from that. That's what I do. So you don't have to remember, did I tell them or didn't tell them? Did I have to tell them this and this and this and this? I'll always do that. Okay? So for example, if I take alginate depressions, it has to be this gram of alginate and this milliliters of water. Okay, for the top and bottom. And they measure it. Okay, so there will be the difference. They do it always. If I say I need a deprogrammer, they already know that it's going to be 5 appointments. So I don't have to tell them when to come back. They already know. It's always. Okay? So in your case, I would say, listen, I need to help you by needing more data.
Right.
Because I don't want to do the treatment, you'll be not happy.
Yeah.
I'm wasting my time and money.
Right.
Okay? So I want to be both pleased. That's why when I do the treatment plan, okay, now what? I can present them different ways of doing it. I will say I don't want to do orthodontics, braces. I can help them, listen, I can have OVD increased, but I have to work on all your teeth. Some people agree. Or nasal spine. Okay? Look at your central incisor. Is it behind?
Way behind.
Okay? So now you know it's a little behind. So I don't need the set. I use my clinical part. You can look at yourself from different angles and see if that position is in there or not. Okay? So, I don't have a tracing here, but you also can see that intercisal angle between the front teeth. And I tell you right now, when I tell the orthodontist, they had no idea. We just told them because they never been taught in school the occlusion. Okay, so if you look at the interincisal angle, what the interincisal angle giving you is the amount of attrition between the teeth. The more the angle, the more the attrition you have between them.
The which angle? Interincisal?
Interincisal. Okay, so if we're going to meet each other and we want to do, let's say, like a edentulous patients, we want to do the implants. Okay, how we can predict is going to be flange there, is not be flange. Okay, and the denture is going to be removable, not removable, where we're going to place the implants, in which teeth. Okay, so we know that so when I deliver the case, it's going to be beautiful design. I have less amount of implants to be placed, but in the right place. But I can correct this position and that position at the same time. What the tracing here is telling us the most. Most people and most dentists been trained to place the teeth vertically. Okay, because you know this incisal edge is right, not wrong. Why? It's a vertical position. But you will never been trained to put the teeth in a horizontal position. So the tracing, the set, is helping you to put in the right position. But again, I just told you about the incisal edge position. That's not what it's supposed to be. If you don't have what the tracing, the machine. Then also, you have to see the root tip of the patient, okay, tools in the front, has to be facing the eyeball in the middle. So you can see the position of the incisor, and also the root probably might be somewhere there, but not toward the position. So what she told us on her interview, that she started having problems when? After the braces. You also have to keep in mind that, remember we have dolichocephalic, okay, faces, when we have long faces, and we have short faces. Okay, I'll make it more simple. So the more quadrangular face, square face, it means the position of the growing the jaw is going to be more forward, he's going to be more constricted because there is no way out. The more dolichocephalic face, okay, because the angle is bigger, it means it will come to gear out from the restriction. So what you need for these patients, when you do occlusion design, you will need steeper occlusion. Steeper means it will disocclude faster. Okay, not shallow. Now you know what design I have to do when I tell my technician to design this case. But again, you have to know how much the space you have to give to this patient. So for example, you have to know that what the shift between CO and MIP. If the shift is very big, you're going to have problems. Okay? What it means, for example, if I deprogram here and the jaw moves forward like class 3 position, and I would say, no matter what I do with this patient, I won't be able to fix her bite with the teeth position, with the braces, because it's an anatomical position problem, the jaw position, not the teeth problem. So when you do deprogramming, people say that, listen, if I do deprogramming, I can change the bite forever and she will never come back. Usually it's not. 99.9% it will come back to you again. So because you do deprogramming, it's only for 24 hours. It lasts. When you remove the teeth, it will go back again. That's why it's very important telling you. The posterior teeth you need for your ingrams, the brain. Okay? To make it more simple so you will understand what the cois does, the example. He said that if you're learning to ride the bicycle at age of 5, 7, 10, whatever the name, okay, and you didn't ride the bicycle for another 20 years, when they handle the bicycle, you can jump and ride the bicycle again. Why is it? Because you have a memory right here. You used to ride this, now you have this. This we call memory, engrams. Okay? So that's why when you deprogram the muscles, because they are in an adaptive position, when you deprogram, they don't have a back teeth to bite. That's what they're making, engrams. The jaw what wants to do is to go to the original position where they have memory chip right here. That's why it goes back again, or goes forward to original position. Follow my steps? Yep?
Yeah.
Okay. Normal is 132 in incisal angle, but she has 142. More friction. Okay, degree. So you also can see this. I have in my office Dolphin software. I've been using tracing, so I trace myself or my staff does it. Okay, so they give me all the data, so I can put it together and make a diagnosis.
Which in that case, if she's overusing the deprogrammer, she's probably gonna have less pain initially, right? Because let's say she gets super eruption, won't that open up the anterior slightly, make it steeper? Not necessarily in a good way,
Yes,
but is
yes
that
and
maybe
no.
why she may be having no pain?
If it will hold the bite in that position, yes. But if it's not, if it's still going to be there, the joint, it also depends on the bite after she deprogrammed. If she's going to still be on the tracheal discal tissue, she will, definitely. Okay, it's going to be a scar tissue around there. Okay, she's not going to feel pain. But my problem is if she will go more behind. That's why, remember I told you about what you see? I do centric and eccentric loading test. What it means to you, that's when I do centric, see I do both joints at the same time, I'm loading the test. Now I do eccentric, it means I load one and another one I keep aside, it's not touching it. So I'll make sure which one is which. And sometimes like her or somebody else, you're going to see that the patient is having have no problems with the loading test, but when I moved to the side and she started feeling pain. What it means? Because you see, I have a joint who is in this direction like a buccolingual, okay, or mesodistal, is more size than the distance than here. So the joint in this position, when I move in this position, where the joint moves back, means this part is longer. Because this is shorter, it's not touching the back part, which is more painful. When it moves back, it starts touching it. Okay, it will help you. That's when we'll go through the anatomy. And you see my emails. Okay, so let's go. Again, another one. And for the light, that's what you're going to fall asleep. So dysfunction. Read. Muscle atrophy. Muscle fatigue. Okay, you can read in yourself. It's generalized wear facets. Wear on incisal edges, maxillary mandibular teeth. Generalized mobility and avoiding chewing or sorting food. What in this case, the jaw wants to move back, but the teeth in a way. It means it doesn't sit. The joint doesn't sit all the way into socket. What kind of symptoms you might probably have this patient? So he might say, Doc, I don't have a bite. When you ask him, could you bite down? He'll tell you which bite you want. Because he doesn't have a bite. It means, when I ask him, it's when you bite down, do you feel your jaw is locked in a position? And the patient said, no, I don't have it. I hardly find the bite. Okay? It means in this envelope of function is very big than normal. It means it's going in a circle way. Okay? Remember there used to be an old version of the bite, rats and cows. Okay, so constricted is rats, cows is dysfunction. Okay, so I'm just giving it, but again, those relations is wrong. So what you see on those teeth, usually, people who you say, listen, do you avoid any hard food? I said, no, I can't eat steak. I have to cut in pieces. So when I want to chew, because my muscle getting tired. Okay. Some people you will see wear on those teeth. Okay. So when you see the wear on the back teeth, you try to do the front ones, beautiful cuspids rise inside the line. Okay. If there is no anatomy on the back, your front teeth will be destroyed. Because I told you, if you wanna shrink the envelope, which been destroyed, became wider, you have to build the occlusion. That's why when you do morphology, make sure the teeth looks like the teeth. Okay, in morphology. Because if you don't build the the anatomy, the envelope is not going to shrink, and your front teeth which you build is going to be destroyed. Okay, that's why sometimes you will see the neuromuscular people on Facebook. Sometimes they're fighting with me. That's because he fractured this tooth because of the tooth number 19 was inclined mesially. Okay, and they look in morphology. Okay, because of the problems. I'm telling you right now because anatomy and because envelope function of the patient is too big and you want to shrink it. Okay, so will you shrink it completely? It will depend on the pathway the patient has, not guidance, the pathway. Okay. What other things what you probably might see, you're never gonna probably see it in articulator. Number one, you will see the second molars, the buccal cusp completely destroyed, lingual still present. Okay, and you've been doing the crown. Yes.
Lower? Second?
Lower. Yeah.
Okay.
You're doing the crown, and patient bite, feels fine. There's no occlusion marks, nothing. Okay? And you put your articulating paper, nothing. But he says, I don't feel comfortable. I touch him. You're filing, nothing. What happens, why is only the buccal wall is destroyed? Okay? Why is lingual wall destroyed on the palate? Okay? The reason is flexibility of the jaw. Okay? When patient squeezes, the only working cusps are moving against each other. Okay? And when it squeezes, it rubs against the buccal cusps on the bottom and palatal cusp on top. But mostly it's buccal cusp on the bottom. You can reproduce this on the articulator. Okay? So you have to see, is all the teeth are normal, there is no wear. The only problems where you have on the second molar. So in this type of patients, I always, when I check my occlusion and filling, crowns, analyze, inlays, ask bite and squeeze. The word squeeze is magic. Okay? Because when they squeeze, jaw moves. Okay? You'll probably picked that kind of problem. Patient has. Another that's what you probably might be feeling in the clinical part, the flexibility with the place rule. Okay? So when you're taking doing 3-in bridge and you patient open the mouth, you're taking impressions. When patients open the mouth to wide, the jaw flexes. Sometimes flexes 0.5 millimeter, a little bit more. Okay? When you get the framework back again, it doesn't fit. Because power function, that's what we call sleep bruxism. Spear has a power function, bruxism, what he call as dysfunction. So I hear them, it's bruxism. It's usually dysfunction. Okay, in the course. Prior function, I want you to read. Destructive use of system, no functional purpose. He's destroying, remember this? Shh, shh, shh. Destroying the teeth. Another thing is what you have to remember. If you give patient a night guard, okay, the traces you will see on dysfunction in a circle. Because that's what she does, patient does. You will see the wear on the deprogram, and this programmer on bite, okay, night guard. You will see this part. In a power function, you will see linear streaks.
So, what is the streaks you said?
Streaks and bruxism.
Oh.
And how do you diagnose? Oh, it's on the
It's
the
in
bite itself?
night guards.
Oh, on the night guards.
Night
Okay.
guard. Okay, if you don't see it, okay, take a night guard, take allergen depression. When you remove, you will see the positive marks.
Mhm.
You will see the traces. Okay,
Power function, you said is the bruxism, is like.
power function, but not it's bruxism,
Bruxism.
Yeah, sleep
and
bruxism.
Dysfunction was
dysfunction.
all the same?
No, dysfunction is dysfunction. in the
Oh,
voice.
just plain dysfunction.
Yes, in it's spear.
Backwards,
Okay, in
All right.
spear.
Power function is bruxism.
Yes, power function is the bruxism is a dysfunction. That's what you have here. For confusing. So, pathological condition of normal function may develop as adaptive. It means people using, you will see like a normal, but actually he has a problem with bruxism. And I told Matt it's the sleep bruxism doesn't happen every day, every night. Sometimes it happens once in 3 months, once in 6 months. So you build occlusion, you will see destruction in 6 months. So look at the history, how the patient break the teeth at the beginning, the wear, okay, and all the symptoms the patient has. So those questionnaires is going to help you a lot. Neurological disorders. Those patients you're not going to see a lot because there's special central clinic. They're going to be referred. The only thing that's what you're going to see is so much starter around it. So you have no idea who you're dealing with. Professor, teaching in a prestige school. That's the patient you want, the quality patient. And you see this craziness he's wearing. And sounds God, he tells the doctor this is what he has. He trying to put a deprogrammer and everything else. And that doctor is my mentor. He didn't know what to do. So he went to course. Help me. Course has also a problem. I told you. The principle works until it stops working. So we put the patient on deprogrammer. This is deprogrammer right here. Compared to here's what he had, and the deprogrammer, course deprogrammer. Look what he did. He went to Home Depot, find the plastic, put the screw into the deprogrammer,
This is awesome.
so he can wear this piece. You understand? Because that's a bite he's comfortable with.
You mean that for himself?
Yes? Okay? I'll show you the picture.
What?
Craziness.
He's MacGyver.
Okay. So that's what we call neurological disorders. Okay?
This guy
The
should go to
people
court
who-
line.
More like psychological disorder.
So what they did, because you see that the bite, how are they gonna make the teeth so long?
Right.
But that's the bite he's comfortable with. It's like orthotic.
Mhm.
Remember? So what they did, they put the deprogram a little bit different way. You know, that's the guard on top, bottom, and the pointy. So they will deprogram the muscles, find the CR, take a CR position, took the impressions, prep the teeth, restore him. And he's still wearing that piece between the teeth.
Yeah.
Okay, that's what comes.
Wow.
That's it.
And he's functioning well, he's not getting super eruption. They're individual
No.
units, right?
Yeah.
How is he not getting super eruption with that gigantic block in
Is he wearing it throughout the entire
He's
day?
not going to wear it when he teaches in NYU, wherever that's
That's what I
he's in
wanna see.
schools. Okay, he does it when he's alone, but he's not going to easily walk around.
This is New York, man, you never know.
Yeah. So I'm showing the case. It's a craziness. I hope you're never going to have this patient in your office. Okay. So this is the clinical signature cases. What we have in the course, every one of us has we have signature cases. On the cases, we learn how to diagnose and to do treatment plan. It means this case is representative of this and this kind of disease. So it has all the treatment to be done, what can be done. Okay? So this is one of the case, and then we're going to have another case. I hope we don't have enough time, and then we're going to do practice. Okay? If you're ready, we'll start. First, acceptable, CCP, dysfunction, bruxism, neurological disorder. If MIP doesn't work, it means it's not acceptable. You follow me? You see how I'm doing CSI? Let me show you this. If it doesn't work, it means I can't build her occlusion in MIP. It's not acceptable function. She also, if she went to a neurologist and he said no, neurological disorders, out. What do we have? Only 3 left. Okay, now we have to figure out is it CCP, dysfunction, or the bruxism. Okay? So what she has? She squeezes, she has headache. Okay, you see the yes marks. If you see the yes marks on any of them, it means there's occlusion problem you have to fix. So what's next? As a previous patient, we have to figure out is it CCP, dysfunction, or the bruxism. She couldn't sleep. She has restless leg syndrome. Okay, she couldn't sleep. It's because she wakes up at night because her jaw is hurting so much that she can't sleep. So it's bruxism, dysfunction, CCP. So I'm trying to again lean forward, maybe CCP, but her teeth are not moving. There is no wear in the teeth. Okay, there's nothing else might not will pull me wrong or right. Okay, so I'm trying to look at her teeth. That's what he said from course, and he said, "Listen, are those teeth when you're done with the braces, have they been even, or they been the same position what you have right now?" She said, "They've been even." But I see it's number 9 is a little bit higher than number 8. You can see the difference?
Mhm.
Do you see it? Yes? It's always been like that? No, it's been a bit straight. But you said that your teeth did not change within the 5 years. I said, I was thinking it was not so important. You understand? So how are you going to find out what the diagnosis until you ask the patients questions? You understand? That's why you have to work as an investigator to find out what the patient has. So if those teeth moved, okay, so now you're implying more CCP because it's restricted and patient wants to move, it happens. If you have still doubt what those 3 diagnostic opinions, put in the programmer. Find out. What he did also, he called his orthodontist and he said, "Listen, I want all the information you have this patient. You've been treating her at the age of 9, okay, till age of 15. Can you show me all the models if you have any SEV and pictures?" But since God, the doctor has all the information. You can see here. Now you can see the age, how the case progresses. Okay, you see the tracing. And you say your brother also take a tracing. And there's nothing wrong with orthodontist. She went to the specialist without having joint problems, but she came with joint problems. And for the rest of her life, she will probably have migraines until treatment would be done properly, if the teeth will be in the right position. Okay? So we figure out and see what can be done on this patient. Remember I told you what, so what, and now what. Okay? So now we have to figure out, we came up to the conclusion with CCP. Okay, because the jaw wants to move forward. Okay, after deprogramming. You will see the initial contact is going to be after deprogramming, write it down. On CCP it's going to be anterior teeth.
Initial contact?
Initial contact after deprogramming. On a dysfunction, it's going to be posterior teeth. So what happens next? Now we have to figure out what to do. 6 months recall, by the way. So my front desk, my hygienist already know, 6 months recall. You already schedule this patient every 6 months. Bio, there's no cavities, she's good, low risk, nothing. When you're done, now what? Your prognostic factors, which have been higher on so what, has to be decreased. It means when you do the treatment, the prognostic factor, the risk factors has to be lower when you start with. And that should be higher. Okay, so when you do the presentation, you say, I done this treatment, and I lower the risk. And why? That's why when you go to be, I hope you're never going to be in front of the judge, people are going to ask you, how did you come up with this decision? Would you tell me the process? Why did you file all the teeth down and create these restorations people cannot eat? So I said, this is what I followed the steps. That's what I did. And all the steps I'm telling you right now, there's a lot of articles and proof. That's what we're doing every day. Okay, it's not just from the sky, it's been proved the concept. So, do you understand this case?
Sort of.
Okay? Here, the patient needs to take the medications. And usually that's acidity. If this is a bite,
Gives you the position to take your bite.
if this is a bite I want to achieve, I can scan top, I can scan the bottom, tell my technician, build the occlusion unlace, the plastic unlace from lava, whatever the material you want to use, come back, there's no injections, there's no drilling, I just cover the top portion of the teeth, place on enamel, and I'm done. Full rehabilitation, 2 appointments, no headaches. And it costs you maybe $60 per each onlay. You can do it on your CEREC, okay? And it costs you maybe, you'll charge maybe a patient $400, $500, up to you. Not $1,000 for the prepping the teeth. Patient save the teeth, okay? And restore the bite, it'll be fine.
You do that as the permanent restoration or is that trial?
Yeah. We have some patients
What about
we
the
did.
anteriors?
What did I?
What about the anteriors?
Anteriors, again, what patient wants. So this patient is,
I have zero exposure to course deprogrammers who you
Yes,
and
yeah,
discuss it,
yeah,
so
yeah.
I have an idea.
so the other way, what he put in the dental history, that's he doesn't like his brown teeth. He wants to make them white. Okay? The question is, how much whiter? Can you achieve that whiteness with the bleaching? Or you have to use the material to achieve the result? I have nothing wrong to file the teeth because for some patients, the discoloration is disability. And I say, listen, I can't, I'm self-conscious about my teeth. I can't. Can you do something about it? It's not going to be me, it's somebody else who's going to file the teeth. Okay, that's why I'm a dentist, to achieve the result the patient wants. Because for him, it's disability. If it's crazy, it's something different. But for them, it's disability. So if they have, as I say, they have 825, okay, I have no problems to make those teeth wider so he can function better. Okay, that's what the patient wanted. So what I'm telling you right now, You see, I have this jig helping you without expenses, those wax ups and everything else to achieve the full rehabilitation case, easy and fast. There's another way you can do this. I know Artie and Matt great in cosmetic composites. Okay, what you can do also, you do the wax up. Then you use suck down Essex with acrylic. Put it down, okay, then cure it, then separate it. So that Bob Margolis, who is teaching, okay, he's also course mentor, he's also teaching that course, and has also his article at the course, how to build those occlusion
Did he really?
with the composites. It's very easy and it's very fast because you already been having this as your reference point to build the occlusion with the composites and not a lot of expenses. So you see, I make that affordable for every patient you have. See? Okay.
Can you bite down when you?
There's a stop there.
It's just one stop, right?
Uh-huh.
Okay.
And it's only on the centrals. These points.
Is it always only on the centrals, Joe?
I'll tell you why. See this plastic? I can add, I can decrease, and the joints are always going to be where? In CR, it's my reference point. Remember I told you CR can increase, it can decrease. So I can control the bite with this device. You want to do composites? Build the composites while this is the patient's mouth. If you don't have time, what you do next?
Sorry, quick question. You said CR will reduce, or CO will reduce, or increase.
OVD, increase or decrease.
Okay, OVD. Okay.
Okay,
While in CR.
yeah, look over here.
All right, I thought you said
Now
CR
look at the
increase,
images
increase.
you have here,
CR is the same.
and look at the images you have here.
So the programmer is fabricated in using a CR plate
Yeah,
registration.
I thought you said you increased,
So it's different.
increased the arm length. I thought that's the downside.
Are you following me?
Mhm.
Okay. So look at the picture. Look at the picture here. Have they achieved this? Do you see what's on top right here?
Like a built up cusps, right?
Yeah. So what I do? Now I want build the bite, I want it. In OVD, I want it. I take a full composite, flip premolar, this bite. I put the composite right here, bite, cure. You do first premolar on this side, you're done. So the bite here and here will coincide. Okay? Now you do the first premolar on another side. Why it's on another side, not to finish this and continue this. The reason is clinical experience. When the patient has a bite on one side and there's nothing here, he wants to squeeze to put those teeth together because to put in contact. In your clinical experience, what you have? You did training bridge here. Patient is fine. Now he come back to the training bridge here. And there's no bite here. You're taking the bite, patient squeezes, send to laboratory, okay, come back, and a bridge in a light occlusion. You look in the models, beautifully occlusion perfectly there. Whites in the model, they have a hard occlusion, perfect occlusion. Here I have no occlusion or light occlusion. Because again, patient what squeezes. Okay? So when it squeezes, what the dentist do? The next one. He doesn't want to come send back. Okay? He already wasting time. So he built the veneers, it's a dentist, because she doesn't wear her teeth, so there's no problem to keep the same bite. The back in CR, in a habitual bite, okay? He did the laminates, and that's it. She'll not destroy it.
What about protrusive, lateral intrusive? all
She
those?
doesn't do it. If she does, it means then they have a problems.
So that was
But I mean,
done.
just part of normal
No.
pathway.
If it's pathway, the people have to do that. If they don't, why you have to use it? That's why
Wait,
I
say
told
it
you.
again? Say it again?
If the patient doesn't do cross over,
Right,
doesn't grind the teeth in the front,
right.
don't use the pathway. Because the person doesn't do that.
Don't use the pathway. What do you mean by pathway?
The pathway, for example, what he said, it's this way, will you check or not check?
Oh,
You don't need it
if they
because he
don't
doesn't.
do that movement.
That's why you're using what temporaries, okay, to check if the patient will knock down those temporaries or not. And usually you keep them for 6 months, because within 6 months you will figure out what the problem is. You understood?
Doing veneer temps, you keep up for
Yes.
6 months?
Yes. You're doing the composites. Let me build composites. If it doesn't work now, you know you have problems. Okay, you want to be safe. Like grinding the teeth, just build on top of it. It's a problem. Okay? So, now so you can see habitual to custom position or not.
Greg,
Yes.